Welcome everyone to today's webinar. I am Emma Beamer with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. We are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel into the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing Danielle Rusella. Danielle Rusella is the President of Customer Solutions at American Well, where she is responsible for all facets of the customer experience, including new business growth, client strategy, products and services revenue, and partnership development and collaboration. Danielle, I'll now turn the floor over to you.
Great. Well, good afternoon, everyone, and thank you. It's a pleasure to be a part of this afternoon's presentation, and it's even more exciting to share the stage with American Well's partner, Cleveland Clinic, and specifically Matt Stanton. We're going to talk a little bit about today's agenda, and I'm actually having an issue. There we go. Today's agenda. I want to share with everyone a little bit about American Well, spend some time talking about Cleveland Clinic and what they are doing specifically with American Well, and then dive into Cleveland Clinic's telehealth strategy. Matt is going to walk us through the implementation process, his experience engaging Cleveland Clinic's providers and patients, some really interesting business use cases, and importantly, Cleveland Clinic's vision. To provide some background and context, I think it's important to understand a little bit about American Well. Make no mistake, we're highlighting today our partner Cleveland Clinic, but I think some of the background about who we are and what American Well does is important. Many of you may know our history and our focus, and there's quite a number of bullets on the screen so you can sort of digest that as I voice over some highlights. We've spent the last 10 years investing heavily in our infrastructure, the services that we provide, how we're changing, how healthcare is delivered, and importantly, we've had the opportunity and the privilege of going to market, developing, and collaborating with a vast array of partners. We take our partnerships to heart. We've had the pleasure of really working alongside so many organizations in their development of programs, how they create, how they embrace technology to deliver services. And we've really and truly been inspired by what they're taking to market. We remain a client-driven organization. Our technology, our services, who we are, what we do, how we think is driven so very importantly by the clients that we work with. Today we support over 200 unique brands of telehealth, all using American Well's enterprise electronic delivery infrastructure. And we'll talk to you about its various uses and how people really embrace this and make it their own. What a true white labeled experience means so that our clients and partners can create and really project their brand, their image, their offerings. And importantly, we take those brands and we allow our clients to asset share through our exchange, which we'll also talk about. Hopefully you can see this next slide. It's a little busy, but it really is a good representation. It's not all of the clients that we are working alongside, but it is depicting a very diverse and growing ecosystem that spans across various markets in a whole host of industries. Today, this represents over 80 million people that have American Well and our technology as a covered benefit. Not to be confused with more than 130 million people that have access to our technology. Interestingly, we've got one common enterprise that all of our clients are utilizing, and they utilize it in a way that's unique to their business, to their needs. This footprint that you see on your screen represents a brain trust of clients and innovators who have joined our journey over the years. And this includes anything from use case creation, to really understanding value, where clients, where partners, where providers, where consumers are driving value and deriving value. The whole engagement of consumers and providers, the creation of new services, the understanding and appreciation of best practices. This is also a representation of millions of health plan members. You can see in that middle box, a really strong footprint. And by the way, this is where American Well got started. So this is a great representation of literally millions of members, employers, consumers, and importantly on the left-hand side, over 65 discrete health systems, representing more than 700 hospitals and over 5,000 of our client providers. These are providers that are seeing their own patients, delivering care in unique ways. Providers that represent primary care, specialists, pharmacists, nurses, care managers, educators, coaches, and a variety of clinicians. So you can see this is a really vast ecosystem, and I'm using the word ecosystem very specifically, because you can see in each of these boxes, while this represents those unique brands I talked about, we have an added capability through our exchange that we can create and share our partners and clients' solutions, their assets, and importantly, if you think about health plans and employers, they demand services. And we're so fortunate that we have such a growing number of providers that represent supply, areas of expertise, unique programs and services. And through our exchange capability, you can literally see this ecosystem and these unique brands being shared by one another. This next slide is a great representation of how we've moved from urgent care to healthcare. We've watched and influenced how our clients have embraced and taken our infrastructure to market. Early days, it was specifically with urgent care. Today, it's all kinds of care. We think about the various services and relationships specific to their business, geographies, patient population, and the providers that participate. And this same infrastructure that I keep talking about, it really caters to all aspects of care, and very importantly, the relationship between these three boxes that you see in front of you. When you think of patients to providers, typically for on-demand care, providers to patients, typically for follow-up care, transitions of care, population health, and a growing number of provider-to-provider interactions. When you think of a provider and a care team, a provider to another provider type, a PCP to a specialist. This next slide is a representation of how we're really seeing use cases spanning the entire care continuum. This is not a hypothetical slide sharing use cases that we hope one day will come to life. I can tell you 10 years ago, it was a little bit like that. A lot of us started out in the top left-hand urgent care square. I will tell you that today it's a fairly common denominator among a lot of our clients. But we've seen that the real value in telehealth goes well beyond urgent care. So when you take a look at a lot of these boxes here, and again, this is just a representation. This is use cases, workflow, unique workflow that is customized to cater to specific populations, to patients, to areas of specialty, to disease-specific conditions. When Matt Stanton talks in a little bit about Cleveland Clinic, he's going to give you their perspective, Cleveland Clinic's perspective, of how they've taken the technology and really embraced this notion of creating very specific use cases to cater to providers, the patients that they're caring for, unique and new services. And this is really how we've seen the industry and our market in particular grow with the use of our infrastructure. I'm going to be introducing you in just a moment to Matt Stanton. Cleveland Clinic has been a great partner, a great friend, a great innovator with American Well these last 4 years. We've had the opportunity to collaborate with them on so many different fronts. And when we say words like client-driven and co-developing and co-creating and really being inspired by our clients, Cleveland Clinic really embodies so much of that. This is an organization led by some really smart people who have really helped to influence not only American Well and where we've taken our technology, but quite honestly, other thought leaders and innovators around the country. They truly have embraced this notion of weaving technology and telehealth into their ecosystem, into their business, into the various ways that they can interact with patients and new consumers. This is a representation, hopefully you can see on your screen, of the very varied services that they are offering around very discrete services and populations. And it really is with my pleasure that I get an opportunity to introduce you to Matt Stanton. Matt's been a great friend of mine personally and to American Well as a whole. Matt and his entire team, including Dr. Peter Rasmussen, have really done some amazing things, and Matt is going to share that with you. Matt's been really focused for a number of years on a variety of telemedicine initiatives, really thinking about technology solutions and how the clinic can expand reach, improve efficiencies, thinking about populations that they're serving today and populations that they frankly can serve tomorrow. And Matt is going to focus and talk with us about how they've engaged providers and consumers. No easy task. And some of the unique things and programs and ways that they've onboarded really a great array of provider types. How they've created business use and value across their business. How they've developed various solutions to really expand their reach. And last but not least, really improving overall care delivery and efficiencies. Technology really does afford that, and I think Cleveland continues to find ways in which that can be used. So with no further ado, let me introduce Matt Stanton, the Senior Director of Distance Health for the Cleveland Clinic.
Thank you, Danielle. I appreciate the kind introduction. Let me bring up my screen, make sure that I'm sharing the correct screen before I get going here. Okay. So I hope you're looking at my slides now. I thought it was important to start with this slide because this is my It's Deceptively Beautiful in Cleveland slide. This is what we use to entice patients from all over the world to come see us in Cleveland Clinic, but I can assure you that this slide does not represent what it looks like today. As I'm looking out my window here, we're being hit by the snowstorm like most of the Northeast. Nevertheless, I am glad to be able to talk to you guys about our telehealth evolution and our strategy. I do like to share what we've done because I think in my own self-interest, what I'm hoping to do is to get this method of care to be increasingly recognized as a legitimate part of healthcare. And I think the more health systems that get involved with this and the more of us that are doing it, increasingly we will find better and better ways to use telemedicine. So I am happy to be able to tell you a little bit about where we got started. And I'll begin with just a couple of slides just about the Cleveland Clinic, just to make sure that everybody has a good feeling for who we are. We are a group practice, first and foremost, a physician-led organization, which is very important. All of our physicians are salaried, no incentives, no financial incentives to do anything except provide the absolute best care, and I think that's been key to our success. One thing that I think is very interesting, if you look in our vision statement here, one of the very first things that we say is we call out patient experience. And I'll be saying more about that as I talk a little bit about our telemedicine program and what that patient experience is like. But that's a good indication as to sort of how we value the patient experience. A few numbers about the Cleveland Clinic, just to give you a sense. Obviously, we are a very large academic medical center based out of Cleveland, Ohio. We have about 50,000 caregivers. We do about 7 million outpatient visits per year. We have over 4,300 beds system-wide. And of note as well, when we put together our numbers in our each year, we always call out access, and access is a very important part of who we are as well. So for the past 3 or 4 years now, we've been offering same-day visits, and we have completed 1.3 million same-day visits. And when a patient calls in, we're able to offer them a same-day visit with specialists, primary care, whatever they're looking for. So access is also another very large focus for our telemedicine endeavors here. This map is just to give you a sense that we are becoming increasingly a global provider. So the places where our logo is called out are places where we have actual physical presence in Cleveland, Florida, Nevada, Canada, 2 facilities in Abu Dhabi, and we are working on opening up our London facilities. So this notion of being a globally integrated health system is also another key point for considering when we talk about telemedicine and what that's going to be able to do for us. And this is how I usually talk about why it is the Cleveland Clinic developed and is developing a distance health capability. There's generally, I would say, 4 main reasons why we're working on this, although the last reason I usually say is the most important reason. First and foremost, first at the top of the list, we are looking for ways to increase efficiency and lower costs. I don't know today in all situations that I can actually claim that telemedicine has driven lower costs. I think we're really still at the beginning stages of learning how to use these technologies. But nevertheless, I think there is an opportunity there for us to be able to increase our efficiencies. Part of this is just about staying current with patient expectations. We definitely have patients that come to us today that will say to our physicians, you know, do I really need to come back for that visit? Couldn't you just see me through Skype or FaceTime? And so people are increasingly asking us for this. Part of this is about expanding our access and our reach around the world without having to build buildings all the time. We recognize that that's not a long-term sustainable strategy to keep building hospitals. But I think the biggest reason is that we are preparing for capabilities that support this value-based care transition that we are experiencing in the United States. There's a lot of capabilities that we don't have that are going to be very important, in our opinion, for the future of healthcare, that enable us to interact with our patients when they're not with us. And I think it'll be more and more important in the future to keep patients out of our facilities and be able to take care of them in places in the home and where they are, as opposed to having them come to our facilities. And I think these are the ways, these types of capabilities like telemedicine are the things that are going to make us succeed in the future. So when we speak about distance health at the Cleveland Clinic, I think it's important to give you a sense of what all is in that and what's not in that. Generally, distance health for us is we look for any opportunity to transform the practice of medicine, increasingly looking to virtualize care and integrate venues with the patient at the center. This, usually we speak about it from a continuum of synchronous activities to asynchronous activities. We have outpatient and inpatient virtual visits that we deliver. Examples of this are a large telestroke program that we have, or our use of American Well's platform for our outpatient visits. We have other things along the continuum that are sometimes a mix of synchronous and asynchronous, things like EICU, where we can both remotely monitor patients across our system as well as other hospitals. But in addition, we can bring in a specialist by video to take care of patients right at the bedside. And then on the far right-hand side with asynchronous things, we do have activities where we do develop clinical apps, and I'll show you one of those later on in the presentation. We have a long-standing remote second opinion program where patients from around the world have sent us their first opinions, and our providers here will render a second opinion, all done remotely. So all of these programs fit into our concept of what distance health is at the Cleveland Clinic, but it's certainly something that's evolved over time. I would say, give you a sense of how this all came to be at the Cleveland Clinic. We've had a long-standing interest in telemedicine. I think back in the 1990s, we were doing some forms of telemedicine. Some of the things that got started early on are programs that exist today. We monitor implantable defibrillators around the world. We have a Coumadin monitoring program for home monitoring. We have a very large e-radiology program. We were one of the early participants in Microsoft Health Vault, if you remember that, and that didn't turn out to be a long-standing thing. Nevertheless, we've always had an interest in trying some of these things out at the very cutting edge. And to that end, I just learned a couple of weeks ago that apparently in 1997, one of our physicians actually read echocardiograms from the space station, and I thought that was a pretty impressive use of telemedicine. Where we are today, we've become a much more organized and taken an enterprise approach to distance health. And this began back in about 2013, where our CEO recognized that this was going to be a capability of the future in healthcare and that we really need to get organized around it. So we've been at this for about 4 years of really trying to organize it. And I think the important thing to recognize about our approach to it, this approach is right for us. It may not be right for every organization, but I think some of the things about our organization being a very large organization with many hospitals, many physicians who are very creative, there's always going to be a constant flux of what my department controls and what we hand off back to the institutes, the clinical institutes to control, and then sometimes we'll take them back. So we haven't taken an approach that all telemedicine has to be under our control and you have to come to us to get telemedicine done. We've taken more of an approach that my team is going to develop basic capabilities, and we should be developing the kind of capabilities that the institutes will find it easiest to work with us rather than develop their own. Now, some of these things, are controlled. We do have one outpatient virtual visit platform. We have one inpatient virtual visit platform. We develop tools for remote monitoring of chronic conditions, and we are working heavily on building population health strategies. But there is always some flexibility, and I think that's important for our physicians to be able to try out things and then bring them to us and give us new ideas. I'll speak just a moment about platform selection. So when we were deciding what direction we wanted to take for an outpatient platform, focusing specifically just on this one platform selection, we were looking for a couple of key things. I think one thing that was very important to us was we needed the ability to connect with patients that had no previous relationship to the Cleveland Clinic. And that was a factor that really pointed us in a direction outside of our existing medical record system. And I think the capabilities of the medical record systems are certainly getting better today as they start to build in some of these telemedicine capabilities. But I think one factor that's still limiting in that regard is that to a large degree it relies upon having a previous relationship with that patient in order to establish that telemedicine link. Another key factor in our selection, and probably one of the largest factors, honestly, was we were looking for a partner who had a very high patient volume track record. I think we felt like this is early enough in the design cycle that we really needed somebody who had seen a lot of the road bumps already, had already designed around a lot of things, and had already fixed a lot of problems. Another important thing, I mentioned patient experience being very important to the Cleveland Clinic. We really wanted to find somebody that had a delightful patient experience. And I can say for certain we looked at many platforms that while they could connect to people, they left a lot to be desired in terms of whether it was something a person would actually want to do or something that they would want to keep on their phone or enjoy showing other people. So I think that was another very important factor for us. And I think, as Danielle mentioned, we really wanted somebody who was going to be willing to undertake design, experience design into account. So somebody that when we found things that we felt like they weren't working the way we needed them to work or things weren't working for our patients, somebody that was going to be very responsive to taking that into account, turning around new design versions, and getting them up and running as quickly as possible. And those were the key factors for us when we ended up selecting the platform that we're using right now. So speaking of outpatient virtual visits for a moment and focusing on that for the next few slides, we did our first virtual visit in September of 2014. We launched with 4 different departments: endocrine, neuro, ortho, and our urological. All of these scenarios were focused on the post-op follow-up visit. That was a good place for us to start, primarily because it sort of took out of consideration a lot of the financial barriers, the post-op follow-up being within a surgical bundle. And not only removing that financial barrier for the patient, but also, as I'll talk a little bit later about, removing some of the hurdles we still needed to face with our revenue cycle team. We launched urgent care in June of 2015, so a little bit less than a year later. And where we are now is, for this year, we're targeting about a 5x growth per month in December of 2017. Today, we have greater than 40 departments using this type of technology with their patients, and I think one of the things that I'm most proud of is the breadth of our virtual visit program at the clinic. I think one of the things that we've done really well is we've got this into the hands of many, many different departments. I think sometimes people feel like this is something for a particular department or this is for urgent care, but I think what our goal has always been is to build this into the DNA of our providers across the entire enterprise, and everybody ought to be looking for ways to use this in their practice. We use it for all sorts of patient interactions, certainly the post-op follow-up visit. We use it for established patients, new patients. We've done shared medical appointments with multiple patients. We use it on discharge follow-up. We've done coaching visits, any number of scenarios, anything that our providers can come up with, and anything that they think that their patients will benefit from, we've probably given it a try. In order to accomplish all of this, I have about 5 people that are just about solely focused on managing department rollouts, and over time we've developed a pretty consistent process for rolling this out to departments, but I wanted to give you that sense for sort of how many people does it take to get to 40 different departments. What I'm showing you here is the landing page for the clevelandclinic.org website. This is our main landing page that you would come to if you were searching for us. And the only reason that I point this out is just to note that here in the middle of this screen where you can see the green box, this is sort of an indication of how important the Cleveland Clinic feels telemedicine is. It's highlighted in a fairly large icon right here on our main landing page. And if I'm not mistaken, I think that our ccf.org landing page is one of the most visited healthcare websites that there is. If you click on that, it brings you to this other web page on the right-hand side. This is our landing page for what we do for outpatient telemedicine, and calling out just the ways in which we use the platform. I think today it's important. There's a lot of communication that's needed to explain to patients what exactly this is. So a lot of this landing page is showing people videos of how you do telemedicine, what it's like. We have testimonials of patients at the bottom explaining how it benefited them. But we do put a lot of focus on trying to market our services. And all of this is resulting in this type of a volume uptake. I've placed an arrow, a blue arrow, at the end of 2016. So we did have a large increase over 2016. And then this indication of what we're supposed to achieve over 2017 is what I spoke to when I said that we need to increase this by 5 times this year. So I thought it was interesting when I presented this growth plan to our CEO, Toby Cosgrove. His response to me was, "That's all? Well, that doesn't look very aggressive given that you're starting from such a small base. And while I had to roll my eyes a little bit, I'm thinking, what other department here promises, 760% growth in healthcare? I do think it's an indication of where his mindset is, that this has to be much, much bigger than we've gotten it to. I can tell you the volume of visits that you see sort of over the course of through 2016 ended up being about 8,000 visits that we've done to date. So we are looking to grow this very aggressively this year. To tell you a little bit about our patient experience, we do track a lot of information about the patient's experience. This probably only represents about a third of the questions that we ask them, and you can see here that in the blue, these are the category, dark blue is where they've indicated they strongly agree, and red is where they agree. So we usually end up with about 80 to 85% of patients saying strongly agree or agree with any number of patient experience questions that we ask them. So like I said, I do think urgent care is a good place to get started, but in thinking about where you would go outside of urgent care, I think this is really where the telemedicine really becomes part of the fabric of healthcare, is once we can get beyond urgent care. I think post-op follow-up is a great place to get started, particularly because how it removes sort of these barriers around the price and paying for it. Home care also has some bundled services where we've found a good use case. Also, as well, pharmacy discharge medication reconciliations, a great place to get started, is these are typically non-billable services. Behavioral health, a well-established use case for telemedicine, and certainly something that we do here. But honestly, I think what we've found is that it's less about a particular use case, and for us it's been a lot more about the right provider, nurse, and administrator. And without any one of these three people being excited about doing this, invariably it becomes very difficult to get it launched. We have done chronic care programs as well. We're coming close to the end of our first try at a hypertension pilot with about 100 patients doing care coordination and coaching using both remote monitoring devices in conjunction with scheduled virtual visits, and that's been a very interesting pilot. I've got another slide on that later. Actually, here, this is the pilot we did, about 100 patients for about 6 months, and this is just trying to graphically show you that we're bringing in data from consumer devices in the home. That information can be shared through Apple Health Kit, is integrated in with our platform with American Well, and our providers can visualize blood pressures in this instance in the context of the virtual visits that they're doing. So we are, like I said, we're coming to the close of this particular pilot. We're getting ready to launch our phase 2 pilot in a few months after that, once we've gathered a lot of the lessons learned. But I think this is really where providers need to be thinking about using telemedicine if we really want to make a difference in our patients' lives. I mentioned that I would show one of the apps that we've developed. I only show this because I think that there is an opportunity for us in the future to combine virtual visits in the context of apps that we're developing. This particular app is used in the context of envision a patient showing up to the emergency room complaining of low back pain. Rather than referring them on to the specialist immediately, they can be provided with this app which guides them through exercises, helps them track their pain levels over time, helps them visualize the fact that as I do my exercises, I get better and my pain comes down. I think there's opportunities, there could be triggers within these apps to say, okay, at a certain point, if you're not getting better, would you like me to connect you through a virtual visit to a provider that can see you for this? And I think those are some of the things we'll probably be working on in the coming years. Danielle mentioned the healthcare exchange, so I wanted to just at least help you visualize that a little bit and understand how it's helped us. I'm showing here a screenshot of my own personal iPhone, and across the top you can see that I have the Amwell app, the Anthem Live Health Online app, as well as the Cleveland Clinic Express Care Online app. When you open up this second screenshot here, when you open up Anthem's Live Health Online app, you can see that the Cleveland Clinic is practicing on their platform. And likewise, on the third shot, when you open up Amwell's, you can see the Cleveland Clinic is practicing on their platform. And our ability to do this is completely and totally seamless. I have the exact same providers who are staffing my Express Care Online that are staffing both of these platforms. They really do nothing differently. When they sit down for work, they are logged on to all of these different deployments. And I think this is important for us. It's opened up a lot of doors for people to discover the Cleveland Clinic that may not have known about us before. I think it's also an opportunity for providers to advertise their services, put their services out there in areas for which they have a unique standing. So I think we'll be looking for opportunities to put up practices on this healthcare exchange in the future for things that the Cleveland Clinic is known well for, like heart and vascular issues. You can see on my second bullet there that I mentioned a Samsung partnership, and this was something that was recently announced at HIMSS, and it's another example of using the capabilities of the healthcare exchange, where our hope is to work towards a partnership with Samsung and a few other providers using American Well, where we will share common practices on the Samsung platform, and people will be able to see options of providers that they can select from on the Samsung platform. To talk a moment about where we've seen some success, as I mentioned, in my opinion, it really comes down to sort of the physician, nurse, and administrator. Any one of these who is skeptical ends up making this a very difficult process to get launched. So our approach across our enterprise really has been there is no staff meeting that's too early in the morning or too late at night for us to show up at and present the concept. We're looking for anybody that raises their hands. That was really our initial take at this. I think we have been aided in the fact that our CEO is such a strong proponent of this and has actually placed the use of virtual visits on every institute chairman's scorecard. So every quarter they have to come into his office and explain how many virtual visits that they've done that quarter. So that doesn't hurt either in helping gain adoption. I think, I've said a few times, I think certainly looking for the places where there's bundled payments, or if you have non-billable providers, that can go a long way to at least getting this started, because it eliminates sort of that discussion with the patient about cash out-of-pocket services, things that their insurance companies may not pay for. Another key thing that's been helpful to us is the EMR integration that we've developed. So early on, we were doing scheduled visits without an EMR integration, and I can tell you once we got our scheduling integration done with our EMR, it enormously increased our ability to get departments launched, eliminated all sorts of training that we had to do for front desk personnel. So now the EMR integration that we have does support scheduling between the two platforms. When patients arrive online, it fills out a lot of arrival information in the medical records system automatically. And we also have a revenue cycle on the back end that is integrated now so that we can account for the patient payments and give the patients credit for what the services they've paid for, as well as give the clinicians credit for those visits. The other thing that's really has been very helpful, and I would encourage everybody, is to gather the patient feedback, their testimonials, their experience scores. Invariably, when we go into these department staff meetings and we're broaching this and there's some level of skepticism, one of the easiest things to do to overcome some of that skepticism is show them that the patients really love this. And I think once they get their first patient experience online, and the patient just starts gushing about how impressed they were that their clinician was able to see them from the comfort of their home, usually that's where we end up seeing our most success. Some of the things that I have to tell you have been extremely painful about this process, and just to make sure that you're thinking about these things as you get started with this, I would say certainly revenue cycle. This is, if you're anything like the Cleveland Clinic, our revenue cycle is really geared towards and wholly designed around insurance coverage, billing for activities on the back end, selecting level of service, sending a bill out, and getting paid later. The concept of bringing in cash at the time of service throws all sorts of wrenches into the revenue cycle process. And honestly, even 4 years later, we are still holding regular discussions to make sure that that we understand what's going on. It's just a never-ending string of things that you would never think of, but reimbursement specialists will see these visits coming through, not fully understand what's going on, eliminate them from work queues that they should have been on, and it just goes on. And the number of people that have to really understand that this approach is slightly different. Certainly, insurance coverage is obviously a large barrier for all of us in this endeavor. I do think, having been involved in many discussions with many insurers, face-to-face talking to them about this, I do believe that it's going to be changing. We are in the process of talking to many of our major payers about this, and I would say that generally they are very interested in paying for urgent care and interested in learning about what else we might be able to do. So it's still going to be a little while, but I think we will get there over time. The EMR integration, while I might have portrayed it on the last slide as something easy that we just got done and has been so helpful in our deployment, is actually there's a lot of work that goes into that. So we've had many people on the Cleveland Clinic side, many people on the American Well side that work on these integrations. There's all sorts of things that you have to think about when you do this. Certainly around identity of the patient is one of the key things that you have to get right. And we're still working on further points of data integration today. I'm sure many people are familiar with all of the legal issues that surround this. And not to go into all the details of the legal issues that you will face, I would say suffice it to say that you need to obviously be working with a lawyer who is interested in making this happen. I think that not all of our lawyers in healthcare have much experience with the field of telemedicine, and it can be such a maddening array of basically non-guidance from all the different bodies that you're always inevitably left with a lot of questions when it comes to the legal front. So I think we've been lucky that we've had a very strong legal team here that has been willing to go outside when we need questions answered and go to outside legal counsel. There are people that specialize in telemedicine, and if that's a possibility, if I were you, I wouldn't hesitate to go outside. I think you can save yourselves a lot of time going to people who really know what the landscape looks like on the legal front. And lastly, another enormous roadblock for us has been the patient and their awareness of this. I wouldn't underestimate, if I were you, as you're getting started on this, the amount of awareness that you have to build on the patient side, because most of our patients are completely unaware that this is an option for them. I think once they hear about it, inevitably they have a question in their mind about, is this really good medicine? This isn't really how I've done it before. So there's a fair amount of talking to them about why this is appropriate for them, that we're only using this in situations where we feel that it's clinically appropriate. And I think all of that is going to evolve as this becomes a more visible part of the healthcare system. And I think that over time, just like many other industries, people are going to become more and more comfortable with receiving healthcare online. And I think there's always obviously going to be certain scenarios where it's completely not appropriate to be seeing patients through telemedicine. And our stance within Distance Health at the Cleveland Clinic has really been, that's a decision that we leave in many regards to the physician themselves. They understand the patients they're working with. They understand when it is or isn't appropriate to be using a virtual visit. And so we do provide them guidance around some of the rules and the laws that they need to follow, but when it comes to selecting the right patient, we usually follow their lead for who the right patient is to use this. I think sometimes when we get started with a department, their natural inclination is to ask my team, well, who's the right patient for this? And honestly, we don't know their patients the way that they know their patients, and so we usually defer to their guidance as to who the right populations are that could benefit from this. When I talk about spreading patient awareness, I just wanted to let everybody know that the Cleveland Clinic is doing our part to help build that patient awareness nationally. So you may have seen it, I'm not sure if you saw it, but we did have a Super Bowl advertisement this year. I can assure you that that does lead to a spike in people that come visit your webpage and download your app. It may not be for everybody, but we're doing our part to build that national awareness for the benefit of all. And I think this is my concluding slide, just to share with you a couple of lessons learned, if I can, real quickly. The training and implementation process with departments can be very long and protracted and can take a lot of twists and turns. So what I would advocate for doing is starting with many different departments rather than doing this sequentially. Our approach has been to start with as many departments as we can, because inevitably questions are going to come up, delays are going to happen, different people move at different speeds, and I think if we had approached this in a very sequential manner and been very picky about where we were going to get started, it would have taken us forever, and we'd probably be way behind the curve of where we are right now. I think another lesson to be learned here is that the patient still needs support in this. I think that our outpatient platform does a very, very good job of holding a patient's hand through this process, but there is still a decent patient population that no matter how much you hold their hand, no matter how much you hope that they're going to get through this process on the app, some of them do not know their Apple ID password, and they cannot download an app. Some of them will click the button that says, no, I will not share my camera with this app. And then when they show up for their virtual visit, it's a black screen. So there is a fair amount of patient support that's needed. It's not completely self-supported. Like I mentioned before, the marketing, don't underestimate the amount of marketing that you have to do to communicate to people that this exists. You really just can't launch this and hope that the providers are going to communicate this to people. You have to build sort of that understanding amongst the patients as to what this is. I think in terms of provider and clinical team resistance, there hasn't been a lot of resistance. I think where we've met some resistance is maybe we do see times where maybe a provider is very interested in doing it, but we haven't done a good enough job of explaining this to the nurse that works with that provider in the outpatient clinic, and then in the end you come back to them a few weeks later wondering why they've never booked a virtual visit with a patient, and you learn a lesson that the nurse wasn't comfortable with this, and if the nurse wasn't comfortable, it wasn't going to be a discussion that was had with the patient, and come to find out that none of these are going to show up on their schedule. So we do have to keep an eye out for making sure that everybody on the team understands why we're doing this, why it's good for patients, what exactly the process is going to be. And then the last one is patient resistance. We definitely have patients who they may resist this because it's outside of insurance, and that's perfectly understandable, and we always offer them the opportunity they can always be seen in person, just like they normally would be. But on the other hand, there's a lot of patients where being seen this way in the end is actually much more cost effective for them, where they can avoid staying over the night here, staying in a hotel, driving, parking, all of these types of expenses. Honestly, I would say in terms of patient resistance, once their provider explains to them that this is the way they would like to see them, most of the patient resistance is gone. They're generally very interested in trying this and seeing what it's like. and then generally when they get onto these types of connections, like I said, they're overjoyed with the experience. So that is what I wanted to share with everybody today, and I'm certainly happy to answer any questions.
Well, Matt, this is Scott Becker, and thank you and Danielle for just a wonderful presentation. The telehealth area is an area, like a couple other areas, that's been talked about for about a decade. It's just the last couple of years you've seen this kind of acceleration, and this has been great information for the audience. There are naturally a ton of questions. Let me start with a couple, and then we'll sort of work through a number of the questions from the audience. You've seen a lot of growth in this. What do you attribute your overall usage growth to? And then a related question that somebody had asked is, you have a team of 5 that sort of heads up your department in overseeing telehealth or trying to grow this. What do those people do, and who's on that team? How did you put that team together?
Sure. So to answer the question about growth, I think a couple of things have driven some spikes in our growth. Certainly marketing, direct-to-consumer marketing. Another thing was once we were able to work with our employee health plan to get this type of a visit covered as a $0 copay like an in-person visit would be, that certainly was an enormous win for us. I think the growth that I'm most interested in, though, is the growth that comes from the scheduled visits with our subspecialists, because that's sort of who the Cleveland Clinic is. That growth is really is just a daily hard-won battle, a grind amongst these 5 people.
Is that hand-to-hand combat with the physicians and providers, or is it with the patient community to get them on board with seeing specialists through this method?
A lot of it is internal to our system. So a lot of it is, we have very complex workflows in healthcare at our outpatient desks. There's a lot of people that have to understand what's happening, or else the whole system falls apart. So there's a lot of education, a lot of training, a lot of setup, a lot of making sure those computer settings are set properly and don't get changed, all that kind of hand-to-hand combat. The 5 people that I have, mostly what they're doing on a day-to-day basis, one of them's a manager, the other 4 on a day-to-day basis are explaining to a department what this is all about, what the ground rules are, how do you get paid, how do we set up, what will it cost us, etc. Then working with them to get providers trained, get front desk trained, get equipment set up, hold their hands through a few practice visits, and start launching their program.
Let me ask you a question about that team. You've got 5 now full-time with you. You're part of a huge system, one of the most prestigious systems in the world. How much do you think that team has to grow over the next couple of years? Do you think about that or have a sense of that?
Yeah. So those 5 are focused really on the outpatient side. So my team as a whole is actually about 25 people. That encompasses all those other programs that I highlighted, some of the inpatient stuff. The second opinion program has several triage nurses that work in there. I think, certainly this year we're probably going to add about maybe 4 additional people onto our team. We may, I could imagine us growing by, 4 to 5 a year for another couple years in order to undertake all of these things. I didn't even really speak about some of the approaches to technology that we want to use in support of the medical home. I think that's another area where we'll start investing time and energy.
And Matt, let me ask you another question as a follow-up to this. Is there a target percentage of total visits that Cleveland Clinic would like to ultimately see through telehealth versus in-person or other methods?
It's yes, there is. It's not. There's not really any logical basis for it, I would say. It's more just our CEO said, well, why aren't we doing 10% of our visits virtually? And I said, well, because that would be about 10,000x growth in 1 year. So then it changed to, well, we should be doing about 1% of our visits virtually this year.
And so how quickly what do you see it as a kind of once you get the wheel going, that you'll be in a spot where it does quickly go from 1% to 3% to 5% as more and more clinicians and patients take to it?
Yeah, I mean, hopefully that one volume graph told the story of what I think we're right in the middle of right now. So what that volume graph looked like was about 2.5 years of it sort of getting going, and then in the past year, it's really started to curve upwards. So we're doing
as it really starts to take off. And
yeah.
Danielle, let me ask you a question. Throughout your client universe, is that the kind of growth that you're seeing, that people sort of start picking this up, and then it takes a couple years to really get the kind of growth going that they want to get?
I would say early days, a couple of years. I would say probably the last 18 months in particular, the pace has dramatically changed. I think, and there's a number of different factors that are affecting that, but I would say, a year into this, you can start seeing some real value and deriving, all kinds of, interesting ways that this can be, monetized and used and affect care and outcomes, et cetera.
And so a lot quicker ramp up than it was a few years ago. And so new systems taking this on will see a quicker ramp up because there's just been more experience out there in the entire community than there was a few years back. And there's a notion of what exactly is the exchange and and how does it benefit health systems and plans?
Do you want me to address that first?
I mean,
that'd be great. Either one is great.
Matt, why don't you take it, and then I can add some additional color.
I mean, from my perspective as a provider, the exchange is a very simple, fast, low-cost way to expose more people to our services. So part of what I was saying through this presentation is that there's a lot of marketing to be done. It takes marketing to get somebody to download your app, but now if somebody has already downloaded Anthem's Live Health Online app, all I have to do is turn on my service. I don't have to convince them to download my app, but I can just appear on Anthem's service and people can choose to see me there.
Gotcha. What's the most effective, and you've talked a little bit about this, but I've got a couple of specific questions on it. Can you point to any specific piece of marketing that's been your most effective for growing your telehealth, or has it been, you said something earlier that rather than starting linearly with one department, you started with several and really had to find champions in different departments, see how quickly it would move in different departments. Has marketing been the same, that you've had to try several different things, or are there a couple of things you could point to that were most successful?
Well, so I think, I think one thing that we did last year, at the beginning of last year, the Cleveland Clinic launched a enterprise-wide marketing campaign for access anytime, anywhere. And we were one amongst about 4 or 5 featured access points, ways in which you can access the Cleveland Clinic. So, that was a very broad campaign explaining to people, how can you get to the Cleveland Clinic? How can you see us? Most of our marketing is email marketing, as it's sort of the most cost-effective way for right now of reaching people and explaining what it is you have to offer them. And it has this nice benefit of being able to sort of hot link people right from your marketing materials straight over to your app, make it easy for them to download.
And I assume that was less expensive, the email marketing, than the Super Bowl commercial.
I would assume so. I'm not privy to how much that cost, but once again, we're just trying to help out everybody else by making patients understand what this is all about.
No, that's fantastic. And Danielle, you had on the exchange. Could you give us a couple more moments on what the exchange is and how that works?
Sure. And I think we tried to just a little bit, but it's an opportunity. We talk about the 200 unique brands of telehealth that our clients kind of take to market. And so with the exchange, we have for the very first time the ability to take these discrete, siloed enterprise systems that our clients are running, both on the provider, health system side, as well as from, the vast network we have on the health plan and the employer side. And we can take these siloed systems and think about, a Cleveland Clinic or, a Hartford or New York Presbyterian or the varied clients that we have and the discrete services they provide around neurology or Nemours with pediatrics, headache programs, burn care. So think about very specific services or providers that might be available or can be available. And what we do through the exchange is make them available to other American Well clients that might represent demand. And so, Matt shared the example of, Cleveland Clinic working together with a population of Anthem's membership, Anthem's Live Health Online membership. So it's an opportunity for our clients to be able to project and share their services, their assets, their programs with others that are part of the American Well ecosystem. It's really a very unique capability that we have. We're kind of, in a way, creating a healthcare marketplace